welcome to our Facebook Live streaming event. I'm Dr. Adrienne Neithardt, and I am part of Boston IVF. I'm a reproductive endocrinologist here, and I see patients out of our Boston area locations as well as in Indiana. And I'm so happy that people are able to join us tonight and still stay in the safety and warmth of your homes, hopefully. Please feel free to type out any questions that you have, and we'll be filtering them, and hopefully I'll be able to answer as many of questions as possible. We have had some people who have pre-submitted some questions, so I'll start with that, and then as the live questions start coming in, I'll answer as many as I can get to. So probably one of the easiest questions, I guess, but the most basic and what everyone's fearful of when they first make an appointment is what tests are actually run when you come to a fertility clinic, and what can you expect? And I think that's a good place to start with the basics. And the way I usually explain it to people is, we're trying to look for we're trying to assess the different parts that need to be there for pregnancy to occur. And so there's a very specific reason behind the testing we do. And obviously it's going to be tailored to each individual person, but there are basic things that need to be there in order to achieve a pregnancy. So you can expect that we're going to run blood work. We like blood, lots of it, to try to assess your quality of your ovaries, meaning your ovarian reserve, the quality and the quantity of your eggs. We're going to look at general kind of prenatal health labs, make sure that your thyroid is functioning appropriately, for example. We then are also going to want to assess structurally your uterus and your ovaries. So, we need eggs, we need a uterus, we need sperm in order for pregnancy to occur. So probably the least favorite test of most women who come to a fertility clinic is the test called the HSG, which is a hysterosalpingogram. And that test can looks at two things. It can show us structurally what's going on in the cavity of the uterus, and it also shows us the status of the fallopian tubes. The fallopian tubes are the conduit from where the egg is picked up after it's released, and the sperm that comes up through the uterus, and that's where they meet. Those tubes need to be open and normally shaped in order to achieve a pregnancy. So an HSG consists of putting a small catheter into the uterus, injecting dye, and either doing an ultrasound or using a type of X-ray to actually see that dye go through the fallopian tubes. And that'll give us an idea about structurally the uterus and the tubes, and we can see the ovaries on ultrasound. We're also, if there's a male involved in the process, we're also going to want to assess their sperm counts. So those are the basic tests that you can expect when you first step foot into a fertility office. So one of the first questions that have come in is, what is the chance of having a miscarriage with tested embryo versus not tested? So just to explain that for everybody who's watching, when we talk about a tested embryo, we mean an embryo that's had PGT-A done. PGT-A is pre-implantation genetic testing for aneuploidy screening. So it's a mouthful, but it basically means that we're taking a few cells from the area of the embryo that's going to become the placenta, and we're sending that for genetic analysis to look at the chromosomes. With PGT-A, we're not looking for specific diseases. We're making sure that the embryo has 23 pairs of chromosomes. Embryos that have a normal testing with PGT have a better chance of implanting and a lower miscarriage rate. If you look at, so this question was, what's the miscarriage rate with and without it? That's really going to depend on the age of the woman when you're talking about an untested embryo. If you look at the average risk of a first trimester miscarriage is probably about 15% if you take all women. If a woman's under 30, it might be closer to 10%. And if you're, closer to 40, it's going to be closer to 20%. When we have a tested embryo, then the risk of miscarriage is about 8% in that range. And some studies have said 5, some have said 10. So it's somewhere in that 5 to 10% range. And I think that's important to know. So PGT-A can lower the risk of miscarriage, increase the likelihood you're going to have an ongoing pregnancy, but it doesn't eliminate it. And so I think, that's important to keep in mind. So I have a question here about how do you increase antral follicle count and what's the likelihood of being able to freeze eggs or IVF success if the count is 0 or low? This is a really tough question, and it's probably one of the most difficult things I think that we face in the infertility world is what we call diminished ovarian reserve. And diminished ovarian reserve, one of the hallmarks of that is having a lower antral follicle count. Your antral follicles are the potential eggs that we can see in very small follicles in the ovary that you can see on ultrasound. So sadly, we don't have a reliable means of increasing your antral follicles or your egg yield. Now, that being said, there are ways to make yourself healthier. Trying to eliminate toxins in your environment like nicotine, cannabis use, too much alcohol, trying to have a healthy diet, lifestyle things that's going to make overall your health better, which is going to improve your egg health as well as your chance of getting pregnant. But if the pool of eggs that you've had is significantly diminished for whatever reason, reproductive aging, past medical history, or reasons that we don't understand, we unfortunately can't make more eggs. And so if your antral follicle count is very low and all your other testing is also consistent with low ovarian reserve, then it may be difficult to freeze eggs. And when you talk about freezing eggs, you don't just want one egg. You need a group of eggs to increase the odds that pregnancy is going to occur from them. So one thing you have to think about is maybe if you do respond, maybe you have to commit to multiple cycles to get enough eggs. But unfortunately, the chance is much lower. There are other ovarian reserve testing that needs to be done with your antral follicle count. I don't think you can look at one marker because there's not one perfect marker. So you really, and you have to look at the woman's age. So I really want you to take all of that into context. Just don't look at just antral follicle count or just AMH. You've got to look at the whole picture together to try to evaluate your overall prognosis. Another question here, which I think is a very common question that I get asked a lot, are to talk about the pros and cons of doing a frozen embryo transfer versus a fresh embryo transfer. And I like the way this is worded because it isn't black and white, and it's probably not the same answer for everybody. When I first started 15 plus years ago, we favored doing fresh embryo transfers because we knew the way we froze embryos, there was decreased overall implantation and pregnancy rates. Well, now the way that we freeze embryos with vitrification, we have a very high survival rate when we thaw the embryos, and your implantation and pregnancy rate is not compromised. So it allows us to have more flexibility, I guess, with how we do IVF. Advantage to doing a frozen embryo transfer is reducing the risk of ovarian hyperstimulation syndrome. And that's, I think, one of the biggest. When we stimulate the ovaries and we get lots of eggs that grow and your estrogen gets high, there's this risk of developing a syndrome called ovarian hyperstimulation syndrome. And if you're pregnant and the pregnancy is producing HCG, that risk goes up of having more severe. If we freeze embryos, the likelihood of getting severe hyperstimulation syndrome is significantly reduced, if not eliminated. And also some studies have shown that it preserves the best implantation rates. When you're doing a frozen embryo transfer, we're much more able to mimic what happens physiologically when you get pregnant. And there's some benefits to that. The biggest downside to doing a frozen transfer is the delay. And we all know that with fertility treatments comes a lot of waiting and a lot of delays, and that just adds to stress and anxiety. So I think for some people, freezing everything, having that delay till you can do the transfer isn't optimal. And the other con to doing a frozen transfer is to do a frozen transfer, we really want the embryos to grow to the blastocyst stage, because that's when they can best be frozen and have a good chance of survival and resulting in a pregnancy. And some women just either don't make a lot of embryos or don't make blastocysts. And in those circumstances, it may be better to go ahead and do a fresh transfer either on day 3 or day 5 and not go ahead and have a not freeze them. So I think in our field in general, we move toward more frozen transfers, and it works for a lot of people, but there's always pros and cons, and every situation is a little different. There's some questions about cost of IVF, and unfortunately, I'm not the right person to ask about that, and it's very individual depending on whether or not you have insurance coverage. And so I would really, I would say if you have questions about whether you'd be a good candidate for IVF and what the cost would look like, to reach out to us, and so that we can give you just more details on your particular situation. Great question. Someone's asking about the side effects of IVF medication, and what should you know about it before starting the process. So the medicines that we use for IVF, it's a mixture of medication. They're basically hormones. It's the same hormone your brain produces, FSH and LH, or an LH-like medication. And it's given in an injection, because if we try to take it by mouth, your body would break it down too quickly. The medicine itself isn't necessarily what has the side effects. Sometimes you can get some redness or burning around the incision, around the injection site, but most of the side effects come from what the medicine is doing. The medicine is stimulating the ovaries to produce multiple eggs. The ovaries get larger, your estrogen gets high. So common side effects during an IVF cycle is a feeling of bloating, mild pelvic discomfort, especially when you're doing activity, breast tenderness, moodiness, all the lovely hormone type of side effects that you would expect. I would say most women tell me that it's not as bad as they were expecting it to be. So hopefully that's the case. So I have a question here about what are the chances for a second embryo transfer to be successful? So again, it all depends, but the kind of in general to let people know, if you've had one unsuccessful transfer, does not decrease your chance of having another unsuccessful transfer. It does not decrease your chance of having a successful transfer, I guess is the way to say it. Meaning, if you go through IVF and you've got 2 embryos and decent looking embryos, and we transfer one back and you don't get pregnant, the next time around you have that same chance of getting pregnant again. When you look at percentages of conceiving, let's just take average chance. So let's say a 35-year-old woman with a decent looking embryo, 50% chance of getting pregnant with your first transfer, 50% with your second one. What that means is that at least probably around 80% of couples conceive within those first 2 transfers. So it's not unusual to need more than 1 embryo transfer. After 2 transfers with good quality embryos, well, then the statistics start to go down a little bit. And that's when I really think you need to start looking for other issues. Is there anything we're missing going on with the uterine cavity or the embryo? Because then you're starting to be a little bit outside of the normal range. But just to be optimistic that you still have a good chance with your second transfer. So there's a question about how can we increase the chance of success for IVF for a woman in her 30s who has PCOS, which is polycystic ovarian syndrome. So in general, women with polycystic ovarian syndrome, and everybody's going to be a little different into how they present with it and what other underlying issues might be going on. But we know that PCOS is strongly associated with insulin resistance and metabolic dysfunction. And 80% of women with PCOS may be overweight, but even the 20% of women who fall in that lean category still have these still may have these metabolic disruptions and increased risk of diabetes. So, trying to be the healthiest you possible going into IVF, meaning, working on your weight. If you are overweight, I don't want you to crash diet and not eat just to lose weight, but changing your diet so that you're eating more, lean protein, fresh fruits and vegetables, limiting your processed foods, your sugars, which naturally will help with some weight reduction, but metabolically improve how you are doing. You want to make sure that you're not pre-diabetic. And if you are pre-diabetic, diet, exercise, sometimes medications to help control that before you go through. Moderate amount of exercise. It does not have to be a lot. Walking a few times a week with light resistance really can improve metabolically how healthy you are. And I think that'll translate into not only your egg quality and your embryo quality, but also hopefully help you have a healthier pregnancy. And that can go for anybody, not just women with polycystic ovarian syndrome, but certainly since there's a higher risk of metabolic dysfunction with that, you need to think of that more closely. There are nutritionists, certainly that can help you with that. A lot of plans out there. And I think it's a great conversation to have with your physician. Let's see what. So this is a great question. When you do IVF, how many embryos are implanted and why? So again, I feel like I'm saying this for each one. It does depend. And it depends on a couple of things. It depends on the quality of the embryo and the age of the woman at the time the embryo was created and whether or not the embryo has been genetically tested. So if you've got a blastocyst, which is a day 5 embryo that's good quality and comes from a woman, 35 and under, we're going to recommend doing a single embryo transfer. Or if you have a good quality blastocyst that's been tested and it's chromosomally normal or euploid, we're going to recommend doing a single embryo transfer, at least for the first 1 or 2 transfers. Couple of reasons for that. One is when you look at the implantation rates of embryos, they do have their best, an individual embryo has its best chance of becoming a baby when it's transferred by itself. So I think to give an individual embryo its best shot, it should be transferred by itself. The other thing is that, especially with high implantation embryos, meaning they've got a really high chance of implanting and making a pregnancy, if we put 2 in, you've got a very high risk of twins, 50% at least. And there's a risk of triplets because 1 or both of those embryos can split. And that happens probably on average 2% of the time. Now, a lot of couples or people going through fertility treatments welcome twins. They want that because of everything they've gone through. And I completely understand that. However, we know that a twin pregnancy is much higher risk. And we can't predict who's going to be the person who goes to term or near term and has 2 healthy babies and who's going to be on bed rest or develop severe preeclampsia or, God forbid, develop or deliver before the babies are even viable. And the more twins we make, the more those risks are going to go up and up and up, which is devastating for couples involved. So, to have the healthiest baby and healthiest mom is to have 1 baby at a time. There are situations where we transfer more than 1 embryo. If a couple's had unsuccessful transfers, we may transfer back more than 1. A woman who has an untested embryo and she's over the age of 37 or 38, those embryos have lower implantation rates, and we may, transfer back more than 1 embryo. All right, so, all right, question about taking CoQ10 and DHEA to improve egg quality, and does it improve IVF chance of success? It's a loaded question. So we know that coenzyme Q10 is important biologically for egg health. It's much harder to prove that taking coenzyme Q10 actually improves your egg health. However, I think there's very little downside to that one. It's generally well tolerated. There really aren't known side effects that I'm aware of. So, I certainly have a lot of patients who do take it, and I don't think there's a big downside. I can't guarantee that it's going to improve egg quality, but little downside. DHEA is a little more difficult. There were studies years ago, weren't great studies, that showed in younger women, so probably under the age of 35 or 36, who had low ovarian reserve and didn't respond well to fertility drugs, meaning didn't make a lot of eggs, may benefit from a couple months pre-treatment with DHEA prior to going through IVF. We can't reliably reproduce that data. DHEA is an androgen precursor, and it's one of those that some women do have side effects when they take it because of it. It is an androgen because it causes acne, maybe hair growth, and it's not something that you want to be on long term. Taking it for a couple months before you start stimulation probably is low risk, but I don't think it's really panned out to improve things as much as we hoped it would. So this question, I'll answer it in a little bit of a different way. So it's asking about the recommendation to proceed using an egg donor over the age of 45. And, every clinic, it might be a little bit differently at how they approach this. Sadly, though, when you look at pregnancy rates in women between the age of 40 and 45 who are infertile, all right, we all have known somebody who's been past 45 who's had an unassisted pregnancy that's been a surprise. But if you look at couples that are struggling to conceive, and most couples in their mid 40s and beyond, it is a surprise. They're not able to conceive on their own. But if you look at the success rate with IVF, it approaches 0 by the age of 45. And there's been some large studies, I think out of Boston IVF, that looking at that. And that's why where we start to say, okay, the risks of using the medication, putting yourself through an invasive procedure may start to outweigh any potential benefit if the likelihood of not just a pregnancy, you want a live birth, is so extremely low that it does approach 0 over the age of 45. And I think that's why you will hear that recommendation. It's a very tough position. I completely understand that. So there's a question about the survival rate when you thaw oocytes, which are eggs, and how that compares to when you thaw frozen embryos. And someone had quoted a 93% egg survival rate. And yes, that's on average, not just the survival rate we see at Boston IVF, but that is pretty standard. You might have some labs that are a little bit less, a little bit more, depending on how much experience, but egg freezing and thawing has become more standardized over the past several years. And so that is a common survival rate. Now, sometimes you will have a cohort of eggs, meaning just a group of eggs, that maybe the survival is lower and lower than average. And there's something intrinsic to that group, whether it was the person or just the group of eggs that just weren't as good, that sometimes you'll see lower or even higher survival rates. When you compare that to, egg survival rate when you thaw it is lower than embryo survival rate. They're both, we use vitrification now for both embryos and eggs, but a good quality embryo, the survival rate when you thaw it is closer to 98%. Some clinics, some people quote 95, but it's high, it's above 95%. And usually egg thaw rates are between 90 and 93% kind of nationally. So this is a good question. Someone is asking about how long after an egg retrieval could you expect to go to the next implantation step? If you are doing a retrieval and you're doing a fresh transfer, then we transfer an embryo back 3 to 5 days after the retrieval being day 0. If you are doing a frozen embryo transfer, some of it's going to depend on whether or not you're doing genetic testing on your embryos, because if you're doing genetic testing, it takes a couple of weeks to get those results back, and then we start prepping you. But most people are able to move forward with the transfer. Usually 4 to 6 weeks later is when we're starting the prep. So you wait, you get your period. If you get your period and you're ready and you're not testing your embryos, you may be able to start prepping. If we're waiting for the embryos to test, there may be another month or menstrual cycle that goes by before you're able to move forward. And I know it seems like forever when you're waiting for this. So there's a question here about an age limitation to transfer frozen embryos. I'm not going to be able to speak, and then they ask 2 parts, does insurance put a limit on it, and also medical reasons. I can't speak so much to the insurance part of it. We'd have to speak to somebody in that department in the office to know if there's any requirements, and it probably very much depends on your insurance. Right now, I believe we will transfer embryos to women who are good medical candidates up to the age of through the age of 50, up till about 51. Now, not everybody's going to be a good candidate at the age of 49. So, you want to be in good health. You have to have a full cardiac and medical evaluation to make sure that you're as low as risk as possible. As you get through your 40s, even if you've got a really healthy embryo, we know the risk of having a preterm delivery, high blood pressure during your pregnancy, diabetes, all really starts to go up. So we want to make sure that we can mitigate those risks as much as possible and that someone is safe to do that. So there's a question from a female couple here asking about, how do you determine whose eggs to use, maybe the best way forward. In this particular situation that you put forward, with both women over the age of 35 and hoping to both use their eggs, I would give some consideration to IVF for both of you, creating embryos using both of your eggs, and then you can transfer them back as you're ready. Because if one person does it and then you wait 2 years and you're ready for your next baby, and the other person's now 2 years older, your window might have closed. So you guys are in a range where your window is more narrow. So I would give some consideration to doing that ahead of time to be more proactive. Again, the way that I handle just in general, when I talk to a female couple who both are interested in participating, whether it's their eggs or their uterus or both, is really take a good history from both people, look at kind of your past medical background, your gynecological background, do some basic testing, looking at, are there any problems with the uterus? What does your egg health look like? And that'll help us kind of determine the order in which we do things. So I'd start with a conversation with a fertility provider and go over your unique situation and then kind of go from there. But IVF and freezing embryos is really the best way to preserve, your reproductive aging. Creating embryos also would allow you to use the same sperm donor for both and not have to worry about that donor not being available in the future. Here's a great question about what does an egg transfer, an embryo transfer look like. So after, the hard part, I think, is the retrieval and taking all those medications and coming in for all the visits. The actual embryo transfer should be fun. The worst part of it is that you have a full bladder. And the reason for the full bladder is as the bladder fills up, it straightens out the uterus, and it also acts like a window. So we do an abdominal ultrasound, kind of look through that bladder, and you can see the uterus where we want to put the embryo. We put a catheter in that's empty first, a mock trial catheter to make sure we're in. And then the embryo comes, the embryologist brings it into the room in a smaller catheter that we just transfer in. You can see a little flash on the screen on the ultrasound while you do that. Then they check the catheter, and then you're free. It really only takes a few minutes. And then we let you empty your bladder, and you go home. So that's hopefully going to be the best part of all of this. So there's a question about how long does it take PGT-A results to come back, and whether or not the lab gives it directly to the patient. So two parts to that question. So in general, 2 to 4 weeks, usually closer to the 2-week mark, but that's generally how the turnover time. I have not had experience with the labs, whether it's iGenomics or another genetics lab, giving the results directly to the patients. Typically, we prefer us to get the results and then be able to call you so we can talk about the results, and you not read them and or just read them and not understand and not have somebody to talk to. So I'm not certain about that, but I don't think they give the results directly to you. So there's a question here about what we call secondary infertility. So this asking if you've had, 2 successful pregnancies in the past, even if they were years ago, and then you're experiencing infertility, and, is that common? What kind of problems can arise? And secondary infertility, which the definition of that just means you were pregnant and previously and had no issues getting pregnant, and now you're having trouble. It's actually very common. And especially if your prior pregnancies were years ago, the biggest impact on a woman's fertility is reproductive aging, natural reproductive aging. So, if you were 28 when you had your first kids and now you're 38, part of just natural reproductive aging is a decrease in the efficiency of the whole process. So even if nothing else is wrong or developed, it could just be reproductive aging that's causing it. And there's 2 main things associated with that. We have a lower pool of eggs, so our reserve starts to decline, and embryos or eggs are more likely to be abnormal, chromosomally abnormal, and abnormal embryos may not implant inside the uterus. And, you don't know that that's happening. It just looks like you're not getting pregnant. Certainly, as we go through our lifetime too, other things could happen. So you could develop fibroids of the uterus that is interfering with implantation of an embryo. Male partners can develop sperm abnormalities. And so, I treat secondary infertility just like I would primary infertility, and check all the basics, even if you've had no issues in the past. So, nice question here. So what is the process of transferring another frozen embryo after a successful first one and had a baby? So much easier than the first time around. Once after you've had a baby, and nobody's asked me this yet, but this is a common question I get, is how long do you wait before getting pregnant again? And there really is good data out there in the obstetrics literature that shows that, 12 to 18 months in between kids is associated with the lowest risk of complications. So, a lot of people are very anxious to get back out there. Ideally, we want someone to have waited a year after having their baby before doing a transfer again. Everybody's situation might be a little different that we would discuss, but that's kind of general guideline. Once you're ready, basically we're not starting a whole workup again. We really just want to make sure that everything's ready to receive the embryo. I always go through someone's history of their pregnancy so we can see, were there any pregnancy complications, anything that we need to look out for or take care of before you get pregnant again. Otherwise, it consists of an evaluation of your cavity, which is usually done by a saline ultrasound, where we put a little fluid in the uterus to open up the walls and then do an ultrasound, and that's to check the cavity, make sure there's no scarring, polyps, fibroids, anything that would interfere with an embryo implanting. Basic blood work, we check your thyroid again, your prolactin, infectious disease screening, and then anything else that's pertinent to you or your medical history. That's the evaluation part. Pretty easy. Blood work, that ultrasound. If everything looks good, well, we prep you for your transfer, probably would mimic what you did in the cycle that was successful, and we thaw the embryo and transfer it back. So it's so much easier when you're coming back for another FET. I do recommend, though, because we know everything can take time in the fertility world, is reach out a few months before you actually want to be doing the transfer. Don't wait till you're really anxious and you want to do it. It'll make it less stressful on you. So I have a question here about what's the process like for an egg donor. I'm not certain if that's asking what it's like for the person who's going to use an egg donor or someone to actually be an egg donor. I would say if you want to be an egg donor, thank you. So when you want to be an egg donor, and this is probably much longer of a talk than I could really answer here. So egg donation, sperm donation is regulated by the FDA in the United States. So, and there's guidelines from our reproductive society. So there's a lot of screening that goes into it. So there's screening questionnaires, just looking at your basic history, your age. If you pass that, we get a little more in depth. And then we couple things that we do. We want to look and make sure you've got good ovarian reserve, because even young fertile women sometimes might not be good IVF candidates. And to be an egg donor, we want you to be able to make a good number of eggs. That consists of blood work and an ultrasound. If everything looks good with that, then we generally do genetic testing. You would have a psychological evaluation, meet with a physician. That's all the screening process. And then from there, talk about you'd go through IVF to retrieve your eggs, and then we'd freeze the eggs. So that's a really quick and dirty part of it, but it is a little more involved. So there's a question about the difference between IUI and IVF. This is a great question too. So IUI is intrauterine insemination, and that's where we take sperm, whether it's from a sperm donor or from your partner, and the sperm is washed and concentrated. So you just have moving sperm in a very small volume, and that is placed inside the uterus at the time the egg is being released. And so what it's doing is just getting a high concentration of moving sperm where it needs to be at the time it needs to be there. In order for IUI to work, you have to be releasing an egg. So either on your own naturally each month, or we give you medicine to release that egg or more than one egg to increase the odds. Fallopian tubes need to be open and normal, because when you ovulate, the tube picks up the egg and the sperm's going to meet it that way. So you need to have open tubes, and you need to have enough moving sperm to have a good chance of that being successful. IUI can treat mild male factor infertility. So if there's lower motility and number of sperm, but not too low, IUI is a great option. But if the sperm counts and motility get very low, especially if they're less than 2 million, ideally you want them greater than 6 million moving at the time you do the insemination. So if they're very low, IVF becomes your best option. IVF, or in vitro fertilization, is where the woman is on fertility drugs to get multiple eggs to grow. We then we don't let her ovulate them, though. We take the eggs out with a procedure called a retrieval, which is done under sedation. It's done transvaginally. And we then combine the sperm and eggs in the lab. So if there's very low sperm counts, we can actually inject the sperm directly into the egg to create the embryos. We let the embryos grow, And then we select the best embryo that we're going to put back into the uterus transvaginally, and we bypass the fallopian tubes. So IVF initially came about to treat women who had blocked tubes when we really didn't have any other options. We now obviously use it for many different things as the success rate of it has really gone up. You know, which one you qualify for, you don't always, like, kind of the traditional thinking was always, oh, you had to do this many IUIs, and if that wasn't successful, then you move on to IVF. Sometimes that's still the case, either by preference or sometimes insurance tells us we need to do that. Some couples move directly to IVF if there's low sperm, blocked tubes, women of older reproductive age. You know, you're going to have a better chance of getting pregnant with IVF because you're taking an already fertilized, developing embryo and putting it where it needs to be. So that's the very quick difference between IUI and IVF. Answered that. There's a question about whether or not pelvic floor physical therapy would be helpful if you're getting ready for an IVF cycle. And I think that's, I wouldn't say that is necessary standard across the board. But if you're someone who has pain, especially with vaginal ultrasounds or GYN exams, and you know, that's causing an issue and it's going to cause a lot of stress because you come in frequently, especially for the vaginal ultrasounds, then I do think pelvic floor physical therapy would be very beneficial. Pelvic floor physical therapy for motivated individuals can significantly help with pelvic pain, things like vaginismus, when you've got the pelvic floor, the muscles kind of spasm. So I think if you kind of fit in that criteria, it would be very helpful for you and probably reduce the stress that you feel during that whole process. Let me see. All right, so someone's asking to talk about the IVF process from stimulation to the transfer. So I will, because I've talked little bits about it. So let me take you through it. So when the way my brain works when I think of IVF, I break it into two separate parts. You know, the first stage is the stimulation. And the stimulation is when you're on the fertility drugs to make eggs, multiple eggs grow. Second stage is the transfer. Often those two things occur back to back. So a question that I get asked a lot from women is, you know, is going through IVF, is stimulating you to make all these eggs grow going to cause me to run out of eggs? And the answer is no, because every month we lose groups of eggs, whether we're using them or not. And so during IVF, you take these injections, which I may have mentioned before, that are subcutaneous injections, meaning it's a small needle that you give in your stomach daily, unfortunately, for average 10 to 12 days. Depends on how fast you recruit eggs and how fast they grow. Those hormones are basically FSH and a hormone called LH. Those act on the ovary to recruit the eggs that are already there. And that's why we get such different responses from different women. Every woman has a different ovarian reserve, and it might even fluctuate month to month in the same person. After you've been on those medicines for a few days, we can monitor you to see how it's working. And the monitoring consists of a transvaginal ultrasound where we see the ovaries, we measure the follicles. The follicles are the small little cysts that have the eggs growing in them. As those eggs are growing, the follicle produces estrogen. So we do blood work at the same time, and the blood work measures estrogen levels. We're also measuring progesterone and LH to make sure you're not trying to prematurely ovulate. We do use another medication that unfortunately is also an injection to prevent you from ovulating as you go through that stimulation. Once the follicles get to the size where the egg should be, where it correlates to having a mature egg, you take an injection that we call the trigger shot, and that trigger shot induces the final step of the egg maturation and makes the egg float basically in the fluid so that we're able to get it out when we do a retrieval. So you take that trigger shot, and about 36 hours later, you have your egg retrieval done. And at Boston IVF, it's done in the Waltham office, which is where our embryology lab and the OR is. It's done under sedation, so you're not going to feel any pain. The actual egg retrieval only takes about 10 or 15 minutes. And it's done under ultrasound guidance, meaning a transvaginal ultrasound is done. And then there's a needle stick at the top of the vagina on either side. We go into the ovary, into those follicles, and suction out the fluid. And that fluid is given to the lab as we're doing it. And the lab is able to they look at it under the microscope and they can take out the eggs. We would then inseminate the eggs with sperm that day. And how we inseminate the eggs really depends on your personal situation. Sometimes we just put an egg with the sperm around it in a dish. Other times we have to inject the sperm directly into the egg. You'll go home after your retrieval that day. You're going to be sore. You're going to have anesthesia. So you're not going to want to do anything for about 24 hours or so. You're still going to feel bloated. Most people don't need anything more than Tylenol, though, and Advil. It's rare to need more than that for pain, but it's not uncommon to be bloated and sore for a few days after. The embryos then grow. And depending on your situation, whether you're doing a day 3 transfer, a day 5 transfer, whether you're doing it fresh or frozen, will depend on what happens next. But typically, embryos grow for the next 5 days. Then you come in for your embryo transfer, as long as everything looks good. And we would take the best 1, maybe 2, depending on your situation, transfer those back to the uterus, and any other embryos that we don't transfer would be frozen to be used for a second try or another baby down the road. If you're not doing a fresh transfer for any reason, risk of hyperstimulation, lining doesn't look good, you're doing genetic testing, or you're doing this to preserve fertility for future, your embryos would all be frozen. You usually get a period 10 to 14 days later, your ovaries are back to normal, and you're kind of back to yourself again. So that's the quick and dirty about what the IVF process looks like. So I have a question here that asks about, if somebody had 4 blastocysts sent off for genetic testing, how many would be genetically normal? That all depends on your age, the age of the egg when you do it. If you look at women under the age of 35, we usually see about 20% of the embryos come back chromosomally abnormal. So 1 out of every 4 might be abnormal. At 35, that's closer to 50%. By the time a woman's 39, we're seeing 60 to 70% of the embryos come back abnormal. So it really does depend on the age of the egg at the time. So someone's asking about thyroid and whether or not that could interfere with having a successful embryo implantation. Typically only if it's uncontrolled. So if you have a significantly underactive or overactive thyroid around the time of an embryo transfer or an early pregnancy, that can decrease the chance of it working and increase your risk of miscarriage. It's kind of a gray zone in our field right now with these mild abnormalities of thyroid, like what we call subclinical hypothyroidism, where maybe your TSH is a little elevated. And there's a thought that we really want that TSH less than 2.5 for the best outcome. That data is not perfect. Most of us do it and follow those guidelines because nobody wants to take a chance. But to answer your question, if your thyroid disease is treated, whether it's under or overactive, and it's been in the normal range and stable, then I don't think that should affect your chance of having a healthy implantation. Fun question. If your family has a history of fraternal twins, does that help increase the likelihood of producing more eggs during stimulation? Not that I'm aware of. And I don't know if that particular study has been done or not. Yes, it does run in fraternal twinning can run in families where some women are more prone to ovulate more than one egg at one time. I haven't really seen that correlated to IVF or not, but that's an interesting question. Someone asked if there's any long-term, like lifelong side effects of IVF treatments. And it's a hard question to answer. IVF now has been around since the late 70s, early 80s. And as far as we can tell, there is not any significant increased lifelong risk of breast cancer, ovarian cancer, hematological cancers, or anything else that we really have been able to identify. We do know that the data sometimes can be a little confusing because there is a slightly higher lifetime risk of breast and ovarian cancer in women who've never had a full-term pregnancy. So whether that's by choice or whether it's because of infertility, and I think sometimes that clouded some of the old data. And I think that IVF over the past, 40 years has only gotten more and more safe, meaning because it's gotten more successful, women are not being exposed to these hormones for as long as they have in the past. So, just a quick answer to a question here. And I alluded to this before. Someone was asking, had a baby about 6 months ago, when's a good time to try for the second child? The medical answer when we look at what's the best interpregnancy interval is waiting at least a year in between. Now, as women are older, and if you don't have embryos already frozen, you may not feel comfortable waiting a whole year because your window is closing. And I would say definitely discuss that with your OBGYN. I would say, though, there was someone asking, like, before, trying for their second baby or using a frozen embryo, should they try again naturally? And again, it's going to depend on your situation. I think in this situation, if at 41, I wouldn't waste too much time trying naturally. The chance of it being successful is and having a live birth is probably small. And if you're not successful with your embryo, the longer you wait, you might run the risk that you're not going to be able to make more embryos. Someone's asking what's the recovery like for an egg retrieval? And overall, it's a mild sedation. Most people by later that day feel good again as far as the sedating effects. Depending on how many eggs you had and how big your ovaries were is really going to depend on how long you still feel kind of sore and bloated. And that can linger. Most people are fine to go back and do their normal daily activity by the next day, though. So you do not need an extended period of time out from work unless you have very physical job. But you might be kind of sore for a few days after that. So there's a question about, does the IVF process reduce the risk of Down syndrome in a woman over the age of 40? So IVF in itself does not reduce the risk of Down syndrome. The only way that can be done is if in conjunction while you're doing IVF is if you test your embryos and you do the PGT-A testing to look at the chromosomes, and that will then screen your embryos ahead of time to make sure you're transferring one back that's chromosomally normal. That will decrease your risk. However, I always have to mention, when you do PGT-A, you're only looking at a few cells, maybe 6 cells from the future placenta. You're not looking at the whole baby or future baby. So there's a very small chance there could be something called mosaicism, where some of the cells are abnormal, some are normal. So even if you test your embryo and you do a transfer and you're pregnant, we still recommend doing the same screening during your pregnancy, that you would otherwise. The risk is much, much, much lower, but it's never zero. So that's just important to do. There's a question here about when to change your protocols when you're having unsuccessful frozen embryo transfers, and who would be a good candidate for doing like a natural protocol. So I generally don't change one after the first unsuccessful if everything looked good. So if the lining looked good, the estrogen looked good, and the person tolerated the medication well, and you didn't get pregnant, I don't think you necessarily have to change. After 2, unsuccessful transfers, then I would consider a protocol change at that point. A modified or a natural protocol really is where the people who are good candidates for that, and I personally love that protocol, but you have to have regular menstrual cycles really to do it. You have to be ovulatory so that you're able to build a lining, and we time the transfer based on ovulation. And sometimes we use a trigger shot just to make sure we're timing it correctly. If you don't ovulate regularly, sometimes we can use a medicine like Femara, which is letrozole, to optimize ovulation. So there still are ways you could do a modified natural protocol, but ideally you want to have pretty regular cycles for that to be successful. So a couple other questions that I got earlier, I want to make sure I don't ignore. So someone asked a question about that they wanted a baby girl in the future, and are asking about whether you can, select for the gender you want, meaning create the gender you want during IVF, or you can only select among embryos. We cannot influence what the sex of the embryo is gonna be. That is just going to happen naturally sorting. When you do PGT-A, you do get sex information on those embryos. I always tell people, though, we can never guarantee that you're going to have a normal embryo of the sex you want. So while it's fine to look for that, and if you've got, a female embryo and a male embryo, and you want to select one to transfer first, that's one thing, but we can never guarantee you're going to get that sex that you want. There's a question here about if pregnancy hormones affect brain tumors. And in general, this is kind of rare to have brain tumors either during pregnancy or someone who's going through IVF. There are brain tumors out there that have been known to increase in size during a pregnancy or in response to hormones. So if this is something that someone's affected with, you want to have a close consultation with your neurologist or neurosurgeon, as well as a high-risk obstetrician who's called a maternal fetal medicine specialist, before even embarking on fertility treatments, because it could potentially complicate things. Let's see. So it's asking if you can exercise too much when doing IVF. So that's a great question. So in general, exercise is good for you. And if you were doing a certain level of exercise leading up to fertility treatments and pregnancy, if everything looks good, you should be able to continue that. The exception is, though, when you're being stimulated for IVF, the problem is that it's not that the exercise itself is bad for you, but the ovaries get large. You've got multiple cysts on them, lots and lots of blood going to the ovary. And especially if you're doing high impact aerobic activity, you run the risk of either those cysts rupturing, which can be painful and cause bleeding, or the ovary twisting on itself. And for those reasons, we usually have people back off on the amount of exercise during the stimulation. You're getting ready for a frozen transfer, or once you're pregnant and everything's stable, I think you can exercise similar to as you exercised before getting pregnant, as long as everything looks good. This isn't the time to start training for a marathon. You don't want to put your body through that extreme stress, but maintaining what you did before, I think, is reasonable. There was another. So here's a question from a single female using donor sperm, asking how many vials of donor sperm are typically needed for an IVF cycle. So in general, you should only need 1 vial of sperm for an IVF cycle. I usually recommend having 2, 1 to use and hopefully 1 for a backup, for 2 reasons. One, if some weird happened and the sperm didn't survive the thaw well, which is not common at all, but you'd at least have backup sperm there. Or if the IVF cycle doesn't go as we were expecting it to, and you needed to stimulate again, having another vial of your chosen donor is important. And over these past few years, we've really seen kind of more shortages in the availability of sperm donors. So that's why I usually recommend, having 2 vials there. Someone's asking is if your first appointment can be, in person or telemedicine. And I think it's going to depend on who you're seeing. I'm doing visits right now by telemedicine for Boston area patients. I know a lot of the doctors like to do their first initial visit in person, so they can meet you, but we probably could kind of meet your needs. So if you have reached out to the office, they will reach back out to you and schedule what seems appropriate and comfortable for you. So so unfortunately, our hour has just closed, and I know I didn't answer every single question out there, and I'm sorry I couldn't get to them all, but this hour really did go fast. And hopefully everything made sense. People learned a little bit of something, and please just reach out to us if we can at all help you in your journey. And good luck to everybody.